Today we are going to talk about polycystic ovarian disease, which people think about one disease, but you have to understand that PCOS is only one part of a broader picture called hyperandrogenism. And hyperandrogenism stands for too much androgenic hormones in a woman, too much testosterone or other androgenic hormones. Now, these androgenic hormones are quite a few. You can have too much testosterone, you can have too much dihydroepiandrosterone, which is coming from the adrenal gland, and so on. So looking at this broader picture of hyperandrogenism, when a patient presents and complains, oh, I might have polycystic ovaries, then the physician needs to sit down and try to understand whether the patient has polycystic ovaries and where these high androgenic hormones are coming from. These hyperandrogenic hormones may be coming from the pituitary gland, which, as you remember from the other talks, is the queen mother gland of all glands. It's by the brain, and it's like a centralized computer controlling a lot of other endocrine glands, including thyroid and adrenal and ovaries and testicles. It could come from a thyroid problem, it could come from an adrenal problem, it could come from ovarian problems. It is important to identify where this is coming from because treatment is very different. So let's take this one by one. Let's say that a patient presents and complains of, I have polycystic ovaries. Then you have to ask, well, what makes you think that you have polycystic ovaries? Do you have irregular menstrual periods or absent periods? Do you have excessive hair growth? Do you have acne? And do you have anything else that might suggest polycystic ovaries? Then you have to examine the patient and see if the patient has any signs of hyperandrogenism. These signs are presence of excessive hair growth called hirsutism, presence of acne, presence of discharge from the breast, presence of skin stretch marks, which might indicate a high cortisol, and presence of obesity, presence of something that's called acanthosis nigricans, which is a discoloration of the skin indicative of possible insulin resistance and diabetes. After you perform the physical examination, then you have to do blood tests to see whether the patient indeed has polycystic ovaries or hyperandrogenism and where this is coming from. So you do pituitary, you do adrenal hormones, you do ovarian hormone. Now, the interesting thing about polycystic ovaries, just the polycystic ovaries, is that it's one of the very few diseases which may be diagnosed by a clinical evaluation, by a biochemical evaluation, or by an ultrasound evaluation. So clinical evaluation would be a woman who has a lot of hair growth, irregular periods, and so on. Biochemical evaluation might be presence of high testosterone in a woman, and then ultrasound evaluation, obviously, to see the cysts in the ovaries. Now, this is also tricky. You have to have a radiologist who knows how to interpret these ultrasounds, because just having cysts in the ovaries is very common, for example, in teenagers and very young women. That's how the ovaries are working. It has to have a certain pearl appearance with peripheral location of the cyst. So it's a very, very specific image of the ovaries on the ultrasound. Now, let's say that the hyperandrogenism is coming from the pituitary gland. Well, that involves a completely different evaluation. Let's say that the hyperandrogenism is coming from the adrenal gland. This again may suggest high cortisol levels, may suggest something that's called congenital adrenal hyperplasia, and so on. Or if it's coming only from the ovaries, then that gives you the polycystic ovarian disease. Also remember that a pituitary cause or an adrenal cause can cause secondary polycystic ovaries because of the high testosterone. So you really need somebody to do this evaluation. Now let's say that the evaluation has been done and the patient has primarily polycystic ovaries. It's not coming from the adrenal, it's not coming from the pituitary, which, as I said, involves other tests and other evaluations. Well, polycystic ovarian disease is not only a pure ovarian disease. You have to think about this patient all along, because this patient might be at risk for metabolic syndrome, obesity, high insulin levels, diabetes, and recently we came to understand that a patient with polycystic ovaries might also be at risk for cardiovascular disease as they age. So the physician has to interpret and make the assessment of all these diseases and try to identify whether the patient has polycystic ovaries as a primary diagnosis or as a secondary diagnosis to adrenal or pituitary problems. And then you talk about other complications of polycystic ovaries. And then finally, what type of treatment are we going to use? Well, it's going to be a different treatment if it's a pituitary problem. It will be a different assessment if it's an adrenal problem, because you have to rule out congenital adrenal enzyme deficiencies called congenital adrenal hyperplasia, which will be the topic of a different lecture. Or it's primarily polycystic ovaries. Well, why do you treat polycystic ovaries? Well, you try to minimize maybe the hirsutism, the excessive hair growth, the acne. You try to regulate the menstrual periods. You try to have the patient ovulate, release an egg if the patient is ready for conceiving, and so on. So the treatment might be an oral contraceptive. The treatment might be metformin if the patient has also insulin resistance or prediabetes. The treatment might be treatment of obesity, and the treatment might be, for example, in a postmenopausal woman who doesn't want to conceive, is just a treatment of hair growth. So polycystic ovarian disease is a very complex disease, and it requires several investigations before you can assume that it's only primarily polycystic ovaries and it's not secondary to another process. Treatment is different depending on what is desirable from a clinical point of view, whether you want to treat the hair growth, the acne, the ovulation, whether the patient has insulin resistance, prediabetes, and so on. So we are going to have the topic of congenital adrenal hyperplasia at a later